Good afternoon. I'm Dr. Dale Bratzler. I'm the Chief Quality Officer here at OU Health and the university's Chief COVID Officer. I'll do my usual update on where we're at in the state with respect to COVID-19, talk a little bit about the trends that we're seeing, and then I'm going to talk just a little bit at the end about treatment of COVID-19 and some of the pitfalls that I ask people to avoid when they think about potential treatments that are out there around COVID-19. So, as of this morning, Oklahoma ranks 7th in the nation for the most new cases per day on average. We've actually seemed to have plateaued right at this moment, but we're still 7th in the nation with respect to new cases per 100,000 population per day. And as of this morning, there were reported more than 8,000 new cases today. We're up to 931,000 cases in the state with 13,125 deaths. So to put that in perspective, in the past week, we've had 78,000 newly confirmed cases of COVID-19 in the past 7 days, and 198 Oklahomans have lost their week by reporting. So the news is that this disease continues to have a profound impact on Oklahomans just in sheer number of cases, and that 78,000 likely highly underestimates the true number of people in the community who've become infected. One of the things I did note, though, is that we had a couple of days where the case counts have come down. So we were consistently running anywhere from 12,000 to 14,000 cases a day. And over the past few days, that case count has come down. If you look at the 3-day rolling average, which I've sent out, that is almost flattened completely the trend over the past 2 weeks. It's down to 8,000 cases a day on average. And then when you look at the 7-day rolling average of new cases per day, we were down to 11,148. Now remember, 11,148 is more than twice as high as we ever got during the original surge of the virus. But we're starting to see that trend line also start to flatten out. So I'm cautiously optimistic that we may be approaching a peak in the number of cases in Oklahoma. I think we need to carefully watch the data over the next week or so, and we'll have a better idea if cases are coming down. Sadly, as I've highlighted before, hospitalizations continue to go up. There were 1,911 confirmed hospitalizations today, with 379 of those people in the intensive care unit. And the one thing I've highlighted before is that the percentage of people in the ICU has come down. It used to be about 1/3 of the people, now it's only 20%, and that reflects two things. The Omicron virus appears to be less severe in terms of causing disease, and then secondly, we're diagnosing people with COVID-19 who come into the hospital for other things that may not need ICU care. So good news to a certain extent that not as many people are in the ICU, but we still have a lot of people in the hospital in Oklahoma with COVID-19, and they require isolation, protect both patients, other patients, family members, and the hospital staff that take care of them. So we're not out of the woods on hospitalization yet, and in fact, because we know that hospitalizations tend to lag behind cases, I'm still concerned that we'll see cases continue to rise that are in the hospital over the next week or two. And of course, the community transmission map that the CDC produces remains entirely red, which again means anytime you're in a community, a county that's in the red, they recommend that you wear a mask anytime you're indoors at events. So that's where we're at right now in Oklahoma, and I'll be happy to answer questions. I wanted to highlight a couple of things, though. As I told April, I'll get on my soapbox here just a little bit about treatments, because there is so much misinformation out there about what works, what doesn't work around treatment for COVID-19. So let's just put it in perspective. I put in a screenshot of the Johns Hopkins website. In the world, there have been 359 million cases of COVID-19 with 5.6 million deaths. That death rate then is 1.6%. 1.6% of the people who've had a confirmed diagnosis of COVID-19 have died from the disease. In the United States, we've had 72 million cases, 872,000 deaths as of this morning. That's a death rate of 1.2%. And then, as I highlighted just a few moments ago, Oklahoma has had a death rate of about 1.4%, higher than the US average, lower than the world average numbers of deaths. That number doesn't sound that high, 1.2 up to 1.6%. So think about that as I make the following points. So here's one of the realities about COVID-19. There's some really good news. The majority of people survive this disease. That's the good news. The majority of people survive, so almost regardless, for most people, regardless of what treatments you go get or take or home remedies or anything else, it just doesn't make any difference. Most people survive with this disease. But what I see happening continually is that people are promoting treatments and they're attributing patient improvement or patient survival to their treatment, when in reality the natural history of this disease is that most people recover and survive the disease. So we see testimonials, we see people promoting things for which there is no good scientific evidence of improvement, and yet they get promoted a lot. So anytime you have a disease with a high survival rate, the only way to know if a treatment really works is to do a randomized trial, a clinical trial, where half the people get the treatment, half the people don't, and both the patient and the treating team are blinded to which treatment the patient's getting. So I see so many different things that are promoted on social media that have not been shown to improve survival or patient outcomes. A whole host of vitamins, antibiotics, corticosteroids. We use steroids in hospitalized patients. They're contraindicated in outpatients with COVID. Other different types of treatment that you've all heard about. Remember hydroxychloroquine, how it was promoted so highly, and then when subjected to randomized trials, it didn't improve outcomes and actually caused complications. So again, be cautious of those treatments that people are recommending that don't work. So as I mentioned, the good news about COVID-19 is most people survive. The bad news is, despite the fact that the death rate is low, so many people are getting infected that the number of deaths is really big. More than 13,000 deaths in Oklahoma, 72,000 deaths in the United States, unbelievable death rates from this particular disease, or 720,000 deaths in the United States. So unquestionably, the best way to prevent death from COVID-19 is vaccination. Reduce the number of infections, reduce spread of the disease, and then, as we know now very well, people who are vaccinated and boosted much less likely to be hospitalized or die from the disease. That is clearly the best way. There are lots of treatments that are being promoted out there. Most of them haven't been studied or shown to be effective in clinical trials. And so I wanted to highlight that there are some patients, though, where treatment is very beneficial. And that's high-risk people, particularly those that have underlying immunosuppressed conditions, because those people are highly vulnerable to the infection and have high rates of complications and death if they get the disease. And so in the handout, I've put the NIH risk stratification guidelines for treatment that we use in our center. And again, the people who need treatment the most, tier 1, are immunocompromised people. Who are those people? Those are people that take drugs for diseases like rheumatoid arthritis or cancer treatment, particularly the blood cancers, leukemia, lymphoma, different types of blood cancers. People who've had solid organ transplants or bone marrow transplants. Those people are at high risk of complications. So when we do have treatments that are available, those should be prioritized to the people who will benefit the most. if you're healthy, you have no underlying medical conditions, and you've been vaccinated, you really don't need to be seeking out treatment at this point, because the reality is your chance of having complications of COVID are very, very low. I don't say zero, but very, very low. We've seen that, and I've shown that in previous press briefings. And so in the handout that you all will receive, I've listed the risk groups and what highly immunocompromised people are. Those are the people that we need to be prioritizing for treatment. So I was going to be on my soapbox a bit about monoclonal antibodies today because since December, FDA has known, the companies that make the monoclonal antibodies have known and reported that the old monoclonal antibodies, BAM-EDI and REGEN-COV, don't work against the Omicron variant. We've known it for more than a month, and yet we kept promoting it, kept using it. As I told one person, I think for the most part, giving those monoclonal antibodies was no better than a placebo effect because it wasn't helping the patient. And we know that it's possible to generate income from having these infusion centers or other things that were giving drugs that didn't work. We know in Oklahoma that about 99% of all new cases of COVID-19 are due to the Omicron variant. The health department reported 98%, but they're behind a week or so. We know that from the CDC data, from our own laboratory, that more than 99% of the new cases of COVID-19 are due to Omicron variant. The old monoclonals don't work. So, in fact, in social media about a week ago, I had posted that people were calling out states that kept promoting the old monoclonal antibodies when there was proof from the companies that make the drugs that they don't work. And in fact, just yesterday, the FDA put out an advisory and withdrew authorization for BAM-EDI and REGEN-COV for the treatment of COVID-19, since in the United States, 99% of all new cases are due to Omicron. There's just no good reason to be giving the old monoclonal antibodies. You subject the patients to a little bit of risk because some people do have allergic reactions, and you're not benefiting the patient. There are so many treatments out there that fall into this category that they're being promoted or used without evidence of benefit. They were very beneficial, those monoclonal, the old ones, for Delta variant and the original wild type virus and the Alpha variant, but they're not beneficial against the current virus that's spreading around the country. So what are the treatments that have been proven to work? 2 antiviral pills, Molnupiravir and Paxlovid, though they're both in very short supply. Remdesivir, drug we've been using for COVID-19 for a long time. We've been routinely giving it to patients admitted to the hospital. Now it is authorized for use in outpatients. And so it is a 3-day infusion. In other words, a patient has to come to a center 3 days in a row. It's about a 1-hour infusion for 3 days, but 50% effective at preventing hospitalization and death. It is an antiviral medication. And of course, the one monoclonal antibody that does work, sotrovimab, but it too is in short supply. So again, if your doctor doesn't send you for sotrovimab or one of these treatments, it's likely because you're not in a high-risk category. So when our doctors order these medications, they have to go through a checklist to prove that the patient's in a high-risk category before we'll even consider giving those drugs to that patient. We need to preserve those drugs, at least currently, for people who need them most, those people who are likely to have complications of the disease. So that brings me to the final topic I'll mention. A lot of interest over the past couple of days in CBD to prevent or treat COVID-19. So I highlighted 3 articles that have been published now. The first one was published by the NIH. It's in preprint, and basically was an interesting study where they looked at a cohort of people with severe epilepsy, and they were taking the drug Epidiolex, which is a FDA-approved, purified, pure form of CBD, which has been shown to be useful for certain types of epilepsy. And in this observational study, they noticed that it seemed like those patients who were on Epidiolex did not get COVID-19 as common as other people age-matched in the general population. This was not a randomized trial. There may have been other reasons that these people with epilepsy taking Epidiolex maybe have different lifestyles that didn't put them at risk of getting infected with COVID-19, but it was interesting, and the author basically said we need to do other studies. And then there have been two other studies that have been published now, one from the University of Oregon, and they basically showed that CBDA or CBGA, two cannabinoids that come from the marijuana plant, basically showed that they can prevent infection of cells in a test tube by the COVID virus. And the other study also showed that if you put CBD in a petri dish with human cells, not only did CBD prevent the spike protein from attaching to those cells, but it also prevented the virus from replicating when inside of those cells. But again, I want to highlight, these are test tube studies. We saw the same thing with hydroxychloroquine in a test tube. It seemed to inhibit the virus that causes COVID-19. But when tested in humans, it didn't help, and in fact subjected them to side effects. So one of the authors of the study highlighted, said, we caution against the use of non-medical formulations, including edibles, inhalants, or topicals as preventive treatment therapy at the present time. Our findings do not say this will work in patients. It worked in a test tube, in a petri dish. It didn't necessarily has been tested in humans. And in fact, one of the two studies found that when you added THC to the mix, the active ingredient in marijuana, that it actually, CBD did not work. So, but the other point I'll make is you can buy CBD anywhere. And honestly, if people want to take CBD, I don't have a problem with that, but do not count on it to prevent COVID-19 because that has not been studied. So I'm going to stop at that point, and I'm happy to answer any questions.
Okay, lots of questions came in. So just on this current subject, what is your, not the CBD, but right before that, what do you think of the idea of being pushed to make ivermectin and hydroxychloroquine available over the counter for COVID?
Yeah, so I certainly, at this point in time, do not think we need to put ivermectin or hydroxychloroquine available over the counter for COVID-19 because, again, I'm not aware of any evidence, strong, good, randomized clinical trials that show that it makes any difference in either preventing or treating the disease. And that's why I made these points. The majority of people, will survive regardless of whether I give them ivermectin or hydroxychloroquine or CBD or sugar pills or salt tablets. It doesn't matter. The natural history of the disease for most people is that they'll survive. What I worry about and what I see happen way too often is people say, well, I took X and I got better. Well, you were probably going to get better regardless of what you took. So that's why the only way we can know in a disease where the survival rate is very high, the only way to know if a treatment works is to subject that treatment to a randomized trial to see whether the patients benefit or not compared to the person that gets the placebo. Just remember, one of the tenets of medicine is that any treatment has the potential for side effects. So we don't like to use anything if there's a risk that there could be side effects from that therapy.
So several questions about hospitalizations. You went into great detail on that, but so we're expected to lead the country when it comes to COVID hospitalizations this week. another one saying Oklahoma ranks worst in the U.S. for the rate of COVID patients per inpatient bed as of the latest federal data released Wednesday. Its rate of 30.1 COVID admissions per 100 patient beds is the highest yet in the pandemic. So what does this say about the state of Oklahoma?
So right now, Oklahoma has high rates of hospitalization with COVID-19. But I personally think it reflects the fact that we have broad community spread of the disease right now. So when people come into the hospital for many common reasons, they're likely, we saw a point in time in Oklahoma where we could have predicted that somewhere between 1 in 10 and 1 in 20 Oklahomans were actually infected with the virus. So people coming into the hospital for elective procedures, people coming into the hospital for car accidents or other medical reasons tested positive for COVID-19 because it's so prevalent in the community. So there's a difference between people that are being admitted because of COVID and people who are in the hospital and do have COVID. I want to point out again that the resources to take care of a patient infected with COVID are the same, whether we're treating them for COVID or they've got a broken bones from a car accident and they incidentally are found to have COVID. We still have to isolate them and have all the risks to our healthcare workers. The other thing is in Oklahoma we have a low vaccination rate, generally, about 10 percentage points lower than the rest of the country against COVID-19. So that puts a bigger proportion of our population at risk for the complications of COVID, particularly hospitalization and death. So we're not out of the woods in the hospitals yet. Again, we're up to 1911. Remember, a year ago, the peak that we hit was 1,994 hospitalizations. We're getting very close to that peak that we had a year ago.
So you brought up vaccinations. We have some questions about that and how that's affecting hospitalizations, which you just explained. Have our vaccination rates gone up since the surge, or have we seen a significant increase in vaccine uptake since the Omicron surge, either prime dose, second dose, or booster doses?
Yeah, so the question is, have we seen vaccination rates go up because of the surge? Has it brought people more commonly? I think the vaccination rate is slowly increasing. It is slowly increasing. I don't know that we've seen a big surge in new people getting vaccinated, and we're way below the average right now in booster doses. That's one area I think we need to really promote, because here are people who have already agreed to take the first 2 doses. The booster dose is really beneficial against Omicron in preventing hospitalization.
A reporter asking if you can clarify about hospitalization. If I show up to the hospital for something like a broken bone and I test positive for COVID while in your care, am I now considered a COVID hospitalization even if I'm able to go home and fight the illness there?
Yes, you are, because when you're in the hospital with that broken bone, the question is, if I come into the hospital for something non-COVID related, I'm in an accident, break something, need to have an operation to repair a broken bone or something, and I test positive for COVID, am I a COVID hospitalization? Yes, you are, because you'll be in isolation. We will isolate your visitors. We will have all of our healthcare workers in personal protective equipment, more than just the routine. They'll be in an N95 mask as an example. Anytime they come into your room, they'll usually be wearing a gown and other things. We have to protect our healthcare workers. We have to protect anybody else that's coming into the system and the other patients. So there are a lot of resources involved taking care of you if you've tested positive for COVID, even though you're in for your broken arm.
And I know you just were talking about this, but so that he has a soundbite. When will Oklahoma see its peak?
Yeah, when will Oklahoma see its peak? Well, again, I'm cautiously optimistic that we're seeing the cases start to trail off or not rise as rapidly. And I have maybe 3 different pieces of data that make me feel that way. Number one, David Kendrick did report that the positivity rate, the percentage of tests that are being done in Oklahoma that come back positive, has started to trail off. In other words, we hit the peak of positivity. We're very early, but that's often an early sign that you're getting past a peak, is when the percentage of people testing who test positive starts coming down. The second thing, just something in our own health system. We see far fewer people today, staff, nurses, doctors, respiratory therapists, other people that work in our system that are in quarantine or isolation. We hit nearly 250 people, and that's come down substantially over the last week or so. So that tells me we're not continuing to see as much community spread, and we're able to keep a bigger portion of our workforce here. And then, of course, the case numbers themselves. The 7-day rolling average has come down a little bit, and the trend line is not as steep as it was. The 3-day rolling average, just the last 3 days, when you look at it over the past 2 weeks, is almost flat now. So again, all are encouraging trends that maybe we're starting to see the end of this surge. And remember, New York, New Jersey, those East Coast states hit their peak at about January 10th. And throughout this pandemic, I've said that we were a good 2 weeks, 10 days to 2 weeks behind the coast states. And so we're at the 26th of the month now. I think we may have started seeing cases peak. And I'm hoping that we see a fairly rapid fall off of cases, though the one difference that we may be dealing with is we have more unvaccinated people in our state proportionally. So maybe our case counts won't drop off quite as fast.
This one is a little different. So I just got back to work after 2 weeks with COVID. I know many people are in my shoes. What do we do now? Do we just go on with life? Do I need to monitor my body for a long-term ailment caused by my COVID infection? Once I feel better, is this ordeal over for me?
Well, it's a really good question. What do I do now? I've recovered from COVID. Do I need to take special precautions or anything else? So there is a little bit of good news that if you're, let's say you're fully vaccinated and you've had COVID, you had a breakthrough infection, you've boosted yourself again. And you've boosted yourself specifically against the Omicron variant. So it should reduce your risk of another infection, particularly anytime soon over the next 3 to 4 months. You should be fairly safe. Second, do you need to monitor yourself for long-term complications? I caution about, we know that people do get long-haul syndrome or long-term symptoms of COVID-19. I caution you, though, about one of the things is if you think you're going to have it, then you may start experiencing those symptoms, whether it's real or not, physiologic or not. So you'll know if you have any long-term symptoms or not from the disease. Remember, the majority of people, do not get long-haul syndrome, so that's the good news. I've seen people that lost their taste and smell for up to a year before they started to recover. So you'll know whether or not you're having long-haul symptoms, but don't dwell on it because as I showed last week when I talked about getting vaccines, people who think they're going to have a side effect will experience a side effect, whether it's real due to the vaccine or not. So just be aware of that. So I don't think you have to do anything special at this point. If you're not fully vaccinated, though, I would recommend that you complete the vaccination series or get the booster dose, but wait, just a while after you've recovered before you get it.
That's all the questions today. Anything else?
Get the vaccine. That's still the best way to prevent complications and death, by far.